Good morning, everyone. I'm going to take you through some of the results of a study we've been doing at the Cancer Council of New South Wales, looking at costs of cancer care, largely using linked administrative health data sets. So when we talk about costs, there's a few different types that we can talk about. There's patient out-of-pocket costs, and then there's two different kinds of system costs or costs to the government. There's the direct system costs, which are things that are kind of directly billable, things that there might be a receipt for, maybe a Medicare reimbursement or maybe the costs of treating someone in public hospital. Then there's also the indirect system costs, which are things that are not so easily calculated, things that like cost to society when someone can't work for 6 or 12 months because they're undergoing cancer treatment. But the one that we're going to be focusing on are direct health system costs for cancer cases in Australia. And to do this, we've analysed participants in the 45 and up study, which, as described earlier today, is a large cohort study of over 265,000 people aged 45 years and over in New South Wales. We followed up these people using the New South Wales Cancer Registry to identify people who had cancer after their baseline questionnaire, and compared them with participants who had no record of cancer. And people were matched by age, sex, local government area, and their smoking history. And we compared the cases and their matched controls, up to 3 controls each, to calculate the excess costs per case, which we're saying are the costs that we can say are largely due to cancer. So the data sets that we're using, it all starts with the big green box up the top there, the 45 and up study. Sorry, that hasn't come out quite so well. And they've been linked to cancer registrations from the New South Wales Cancer Registry. Then the 3 kind of purpley boxes in the middle there are the health system use. So it's inpatient hospitalisations from the admitted patient data collection, Medicare claims data, both the Medicare benefits schedule and the pharmaceutical benefits scheme. So essentially any time someone used their Medicare card, there's a record. And the emergency department data collection. And we also looked at the survival outcomes using death records from the New South Wales Registry of Births, Deaths and Marriages. And the types of costs that we looked at included annual and monthly costs around the time of diagnosis, so whether it was how much the costs in the month before diagnosis or the first year after diagnosis or the third year after diagnosis, whatever it might be. We also looked at phase of care, so the initial treatment phase, the continuing care phase and the terminal care phase, as well as prevalence costs, which I'll explain when we get to that. So the first set of results here, we can see we've broken down by the 10 most common cancer types in Australia. And from our sample, we have each of these columns represents one of a year relative to diagnosis. So we can see that the big blue column for each one is the year after diagnosis, and the index hasn't quite come out as I'd hoped. The subsequent years after that, you can see the costs drop off, but really the largest kind of costs through the whole cancer journey is the first year after diagnosis. We can see that there is some variation by cancer type. Prostate and melanoma both had the relatively lower costs. For all the others, it was up in the order of around $40,000 in the first year after diagnosis. And that's the cost to the health system per patient. We also looked at the monthly costs by survival time. So this is looking at the costs in each individual month relative to the date of diagnosis, and it's been broken up by the survival time for the different cases. So the red line there represents the cases who died within 1 year of diagnosis. The yellow line is people who died after 1 to 2 years. The green line is 2 to 3 years. Purple line is people who died after 3 to 4 years, and the blue line at the bottom is people who survived for longer than 4 years. And you can see that from very early on, there is some separation in the level of costs. So the people who have a shorter survival time have higher initial costs, perhaps undergoing more intensive treatment. But then for each of them, the dashed part there is the costs at the end of life. And for each of the different survival groups, we find that the cost experience towards the end of life is almost identical regardless of how long people have survived. So it's really the last 2 to 3 months of life, there's a really steep increase in health system costs. And we also looked at cost by phase of care. There's 3 different phases that we investigated. So there's the initial treatment phase, which was around $28,000 per case. There was quite a bit of variation by cancer type. As mentioned earlier, melanoma and prostate cancer were at the lower end, and higher for colorectal cancer and non-Hodgkin lymphoma. The continuing care phase, so the time after initial treatment, but before someone has gone into terminal care if they've died, or just beyond the initial treatment phase if someone has no record of dying. So again, melanoma and prostate cancer were at the lower end, and higher treatment costs for some of the cancer types that had more intensive treatment, such as leukemia. And then the terminal care phase, which is up to 12 months at the end of life for people who had a record of dying, that was up around $48,000 per case. There wasn't as much variation in the terminal care phase. Those cancer types that were at the lower end were still relatively high. But again, there were cancer types where the costs were higher. And we're also able to look at this by the source of costs. So this will come out well either. So if we look at the initial phase there, 63% of costs were inpatient hospitalisations. 21% were from the MBS, 15% were from the PBS. Then when you go into the continuing care phase, the proportion of costs that were ascribed to inpatient care dropped down to 40%, and it was largely taken up by subsidised medicines in the PBS. But then in the terminal phase, the costs are almost completely dominated by inpatient hospitalisations. So the final kind of method of presenting costs that we're going to look at now are what's known as prevalence costs, which is looking at the costs of all cancer cases in Australia for a single calendar year. And what we've done here is taken the Australian incidence and mortality statistics by cancer type. We've applied that to all people who were diagnosed between 2009 and 2013, and said of the people who were alive in 2013, these are the costs that they incurred to the health system. So these numbers here are millions of dollars. So that top left one there is saying that prostate cancer, there was $349 million worth of costs in total for all prostate cancer cases who were within 1 year of diagnosis, 58 million for people who were more than 1 to 2 years, and so on. And so when we add this up across all of the different cancer types for people up to 5 years since diagnosis, the total cost of care in Australia was around $6.3 billion. And as Karen Canfield mentioned this morning, the highest amount, the highest proportion were for colorectal cancer patients. And a lot of that came in the first year after diagnosis, where with such a high number of cases and almost everyone having surgery, that led to the highest level of costs. So the implications of all of this, the costs of cancer care are substantial and vary widely by cancer type and time since diagnosis, which seems pretty obvious, but this is one of the first times that we've actually been able to quantify the variation, and this has only been possible through these large linked data sets. The data sets allow for detailed, comprehensive calculation of individual level costs with regularly updated data. So we've published a paper looking at cases who were diagnosed up to 2010. These results here up to 2013, and perhaps next year we're going to get an updated extract of the data set, so we can look at more recent cancer treatment types and the cost implications. And the results of all of these can be used to evaluate potential cancer control interventions. So if we were to shift stage distributions, if there were higher numbers of certain cancers, lower number of other cancers, what this would all mean for the health system. And I think that's it. Thank you very much.
Thanks, David. We've got time for one question, if anyone wants to break the ice. Okay, I'm going to break the ice for that one. I like the study, I like the design, it's got matched controls. Did you find any subgroups where a small group of people had accounted for a disproportionate share of costs?
Yeah, it's when we started getting to some of the smaller cancer types, there might have been the occasional case who had very, very high costs. It also went the other way, where some of the controls had extremely high costs, and it's a reflection of, with the ageing population, following them for 5 years, 10 years, people had some pretty intensive medical interventions. There was no one group where we'd say this was really unusual, but we haven't really had time to go in great detail, and that is something that we could be doing for years, looking at all the different patient groups.